Hey, hello everybody. This is Sherry from the CGH Health Foundation, and welcome to our Facebook Live program this week. Once a month, Dr. Bird lets us crash his party and do one of our Growing Healthier programs. And so this month, since it is Breast Cancer Awareness Month, we will be talking to radiologist Dr. Keith Pham and Gina Grennan, who is the director of the CGH Diagnostic Imaging Department. And they're going to be talking about breast health and diagnostic tools that we have for detecting breast cancer with Dr. Bird. But before I turn it over to them, I just wanted to remind you that the CGH Health Foundation's annual Delicious Designs auction is going on right now. The proceeds from our special fall auction are always used to fund our women's health programs, and that's where we can provide financial assistance for mammograms and gynecological exams to women regardless of their insurance status. The bidding opened this morning at the auction. This year, we're also going to be designating a portion of the proceeds to our OB moms, helping to fund some additional mental health services through our Ways to Wellness program. You can find the link to the auction on the CGH website under the Foundation tab, or by going to CGH's Facebook page and looking for the recent post that has the auction link there. Next month, our Growing Healthier program is going to be called Diabetes Interpreted, and our guests are going to be Dr. Angel Vasquez and nurse practitioner Christina Miller. And November's Diabetes Awareness Month, and in that program, we're going to be presenting it both in English and Spanish, and focusing on how we can care for the members of our community who have diabetes and who are Spanish speaking. So you can watch for that program on Thursday, November 11th at noon. And with that, I will go ahead and turn it over to Dr. Bird.
Thanks, Sherry. I think it's interesting that if you have any of those delicious design treats, you're going to need to sit in on the diabetes thing next month, because there's a lot of sweets going down the next day or so. They're going to be auctioned off. Anyhow, good stuff. Thanks, Sherry. And I'm going to bring in Gina Grennan and Dr. Keith Pham. Hey.
Hello. Hi there.
These are folks, if you watch us on a regular basis, Dr. Pham and Gina have been on here at least once before, maybe a couple times. So welcome back.
Thank you.
Thank you for inviting us.
Yeah, and I thought the thing that made sense with this conversation today is circle back on, it's still relatively new, the 3D mammogram, the tomosynthesis mammogram that we're doing at CGH. Now that we've had that up and running now for, gosh, not a year, but definitely enough months that things have kind of settled in. So I wanted to catch up with the two of you and ask you some questions about that. Does that sound good?
Sounds good.
Okay. All right. And as I ask these questions, Dr. Pham and Gina, I'll let you both go back and forth with that. And you can both add into any of these questions here. So first question I want to just throw out at you was, what's been the experience of patients with this new 3D mammogram machine?
I can take that one, especially being a woman. I've actually had my new exam, my yearly exam on this machine. But the feedback is pretty consistent. The women are excited. It's a little bit quicker. The compression is a little bit less, meaning you don't feel squeezed as long and with as much pressure. And then I think the biggest part is just the confidence of knowing that the detection is a little bit more sensitive. And somebody like myself that has dense breasts, I normally am a callback with regular 2D imaging, and I wasn't a callback this time. So that was a relief on my mind, and it just increased my confidence that we were seeing a little bit more.
Sure, that makes sense. Sure, good. Well, I'm glad to hear that. That was kind of the hope in doing this. If I remember right, Gina, you did say one of the things that patients have to be aware of, they have to hold their breath for a little bit longer. What's that time frame?
It's like 20 seconds, if that. It's not that long at all, which doesn't sound like a long time, but if you're compromising your breathing, it can be a little bit, but the technologists are really good. They work with you and they can help you with different breathing techniques.
So it's pretty rare that that's an issue.
It's very rare it's an issue.
Okay. All right, good. Just wanted to make sure on that.
Yep.
So how about the staff? What's been their experience with this new machine?
I think it's a lot like the patients. The confidence is that we're helping our community more is huge. Just like any new piece of equipment, there's a little apprehension. I mean, this is, like getting a new car. You got to learn the buttons and how to operate it. We provide our staff with what we call applications. That's where the vendor comes in and they teach us how to use it. They have clinical specialists. So the longer we use it, the more comfortable we feel, the better we're able to troubleshoot it. So I know our staff very well. The women that are doing the imaging are so excited to be able to provide this for our community.
Yeah, good. One of the things I definitely wanted to ask today was, at least from what I'm reading and what I'm hearing, that there's been concern in the medical community about that patients have been holding off on preventative testing like mammograms. What are your perspectives on this? I'll let you go first, Dr. Pham.
Yeah, so we experienced this at the very beginning of the COVID, around March, April, and May and on, when there is a very strict shutdown of elective procedures in the hospital, and mammogram is an elective procedure. We do have see a surge in the advanced breast malignancy the following months. So we have patients either not going screening or have a clinical finding like a palpable lump or skin abnormality, and they delay going to have it evaluated. And when the elective procedures are slowly coming back, and we saw a huge surge in terms of the advanced cases, which is very concerning at that time. And we hope, and with the way the COVID going, I highly doubt that the strict shutdown will happen again. Nevertheless, a lot of this is coming both from the policy standpoint, also as well as a patient perspective. A lot of patients are worried about the COVID. Every time there's a COVID surge, people do not want to go into the hospital. The reality is the hospital, our department and hospital in general are extraordinarily safe. The transmission in the hospital, as you know, Dr. Bird, is virtually unheard of. Most of the transmission are actually in the community. So, this all our staff is either vaccinated and they're all wearing masks. Therefore, the procedure is safe for both the diagnostic screening mammogram as well as the procedure when you do need to have a lesion sample. So with our experience that seeing the surge in advanced disease the months following up the shutdown, I would advise patients to continue to keep their schedule, and if they have a clinical findings, please do not delay. Now, there's a caveat in what I just said regarding the vaccine process. And the statement regarding the vaccine process, because in some patients, they are sensitive to the vaccination, and they may create a lymph node in the axilla. And you will know it. This lymph node will let you know they are either tender, there's definitely some swelling. The recommendations after the second doses are basically you're going to wait 6 weeks for an elective finding. Now, keep in mind, if you feel a lump in your breast or you have a clinical finding in your breast before the vaccination, don't delay. Obviously, that clinical findings were exceeding the vaccination. And, for the patient who decided to have vaccination, we have an upcoming booster shot. I believe the same rule will apply because if you have a reaction and there is a response, a reactive response to your axillary lymph node, the lymph node in your armpits, chances are you're going to have it again. And, if you either plan around it, you either want to go to have a mammogram done, if it is truly elective, before the vaccination, or wait 6 weeks after that. So make sure we don't see anything we're not supposed to see.
Yeah.
With that being said, if you have a symptom, please go.
Good. Thanks, Dr. Pham. Anything you'd want to add to that, Gina?
No, I agree 100% with that. We are, now that things are trending down with COVID, we're happy to see women are starting to get back on their regular screening schedule.
Okay.
And I also want to add that since we we have been doing this thing for about almost a year now, right, Gina?
Mhm.
And the adoption of the new technology from patient is overwhelming. I for majority 99% of the patient who ended up having an elective mammogram, either diagnostic or screening, they choose to have a tomosynthesis. Very rare that I see the diagnostic screening exam was done with the routine, and this patient usually is that they either they very they have comorbidity, they cannot hold their breath for more than 5-10 seconds. I think the breath holding is a lot less than 20 seconds. Um, and therefore they won't be able to hold still or hold their breath, and that's very rare. The overwhelmingly patients ending up my work list every day is virtually almost always 100% Tomo.
Yeah, good to know. I appreciate that. One of the other things that's changed with this new piece of equipment is also about how we do breast biopsies for patients who do have abnormal mammograms. Can the two of you kind of speak to that for the folks listening?
I can speak to that because we are the one who do the most of that. So traditionally, before the tomosynthesis, we do the exam on the upright machine. But when we ended up with the biopsy, we do the biopsy, particularly with the breast biopsy, stereotactic biopsy. We have to do it with the prone table. Now, the prone table laying on your stomach is not for everybody. So from time to time, we have issue with the patients who can tolerate the diagnostic exam, but won't be able to lay down prone for the biopsy. That has changed because with the current technology, with the new machine, exactly the machine that they are doing the diagnostic exam on, we're going to perform the stereotactic 3D biopsy on the same machine. So if they can tolerate the diagnostic imaging and the abnormality is seen, they should be able to tolerate because it was the same machine. And the process, familiar to us, but much better tolerated with the patient because they're going to be sitting upright biopsy.
Yeah.
We have done virtually all our stereotactic biopsy for the last few months under the new machine, and it's went well.
Yeah, good. Anything you want to add to that, Gina?
No, the techs like it also. They have the patient sitting up. There's a little bit less lightheadedness as far as the patient's already upright. So I agree. Yep.
Patients are tolerating it well.
Yep.
Okay. All right. That's great. That's great to hear. Speaking of, like, if you have an abnormal mammogram and you need to have a biopsy done, so what's, just for patients who are listening to, what's the process for that? What's the process from the time you have a mammogram and it's not normal, and who contacts them, and how does it all get set up?
Yep, I can start the process and then I'll let Dr. Pham finish it. So you come in for your routine screening, and then Dr. Pham will read it, the radiologist will read it, and if you're a callback, our nurse navigator, Erica Adams, will call you. She'll talk to you about being called back, and then we'll set you up with central scheduling. You'll have your diagnostic. Depending upon the recommendations from the radiologist at that point, then we'll go into the biopsy or callback process again. Dr. Pham, you can take over from that point.
Okay. Sure. Yeah. So after the screening exam, which is the word screening implies the patient is completely asymptomatic.
Sure.
If there is things that we need to additional evaluation, a lot of time mostly is under ultrasound. We do an ultrasound or mammogram, depends on the abnormality, and that is up to the radiologist's discretion. One the decision to sample to biopsy, there's two ways to go. Number one is ultrasound guided biopsy or stereotactic guided biopsy, which is now performed under tomosynthesis machine. The timeline is extremely short. We read the screening mammogram in a matter of a day, and then, like Gina mentioned, our breast nurse navigator Erica, she's gonna call the patient and arrange the first convenient, whatever the patient can come in for a diagnostic exam. Once the diagnostic exam is done, the patient is informed on the time of diagnostic exam that if this lesion go away, and basically nothing to worry about, or this is something need to be sampled. And we talk to the patient on the same day. Basically, if we decide to biopsy this lesion because there are features that worrisome, I myself and my colleagues, we will go talk to the patient, discuss, what's on the table, and we can set up an appointment right there and then. So a lot of time it's the patient got their busy life with scheduling, and to fit in our procedure, as well as if it was done on the ultrasound, we want to make sure the ultrasound is available for that sort. So, but we usually get the exam from the screening to diagnostic evaluation and biopsy in a matter of days. A lot of time within a
That's
few
great.
days. Occasionally, we do it on the same day. If it's available and the patient willing to do so.
Yeah.
So that can be done in very.
Right. I'd like to add with 3D tomography, the callback rate is a lot less than regular traditional 2D. Just like I gave you the example of myself, I was always a callback and now I'm not. And I think the other thing for women to understand, it doesn't, just because you're callback doesn't mean you have breast cancer. It's just they need to take a closer look at something.
Yeah. Good point, Gina. Thank you. Speaking of reading them and those type of things, Dr. Pham, what's been your experience now that you've had a number of months on your belt of reading these mammograms?
Well, just to make sure we're on the same page, a routine digital mammogram, the before tomosynthesis, including 2 images on each breast for screening, so a total of 4 images. Nowadays, a routine screening mammogram for a patient about 200 or 250 images. Well, that doesn't mean that it's going to take me 50 times more to read those exams, but it does take more. So I would say about double or 3 times more time to reach each exam. And as everything else, we have a learning curve. And I think we finally it's a plateau, improving on our reading time. So there are the ways for us. I mean, the reading protocol is pretty smooth, and I think we finally reach our efficiencies to reading this exam. So it does take longer because there are more imaging, and then you get to see more. You need to evaluate things more, and like Gina mentioned, there's 2 sides of the coin. You're gonna call things that are not there less, but you also see things that you didn't see before. You call it more. So this is the better exam. We improve both sensitivity and specificity. You don't want to call back the patient that doesn't have anything. You also don't want to miss the patient that you didn't see well before.
Yeah, good point. Hey, for Jackie, as a patient has been through this, Eric is amazing at getting you through a stressful situation. Great job to the whole department. Thanks, Jackie. Appreciate that feedback.
Thank you.
And I agree with you 100%, Jackie.
We are very lucky to have Erica.
And the rest of that team, that they do a great job. So
our whole team.
Yep. Hey, one thing I forgot to mention when this whole started, we started doing our interview for the folks who are watching this. I still will talk about COVID after we get done with the interview with Gina and Dr. Pham. I'll have a little bit of time here at the very end of that, just so you know. Okay, so moving on to that. So just practically speaking, Gina, so for a woman who wants to set up a mammogram appointment, what's that process?
It's easy. Call the hospital main number, 815-625-04,000, and call Central Scheduling, extension 5550. A mammogram is a self-referred exam, meaning you do not have to have a physician's order for it. So call, set yourself up. We'll get you in. We're very flexible with the scheduling, and we want to get you screened. That's the first step and most important part of detecting breast cancer.
Yeah, very good. And one other thing about that is, so just from a cost standpoint, you want to just speak to that too, Gina?
Sure. So the Health Foundation sponsors us. So what happens is there's no out-of-pocket expense to the patient due to the fact that once your insurance covers or doesn't cover, whatever's left, the Health Foundation will pick up the out-of-pocket expense for you. So we're trying to take that financial barrier out and away from people so that they go in and get screened. And not only does it cover screening, it covers lots of other women's services. So if finances is apprehension for you, please call Central Scheduling. They can give you the whole list of everything that the Health Foundation helps us with.
Good. Okay. Thanks, Jen. I just want to make sure we're clear on that too.
Yes.
One of the things once in a while that will come up, Dr. Pham, is, okay, I'm getting mammograms, I'm getting radiation. Are there any concerns about the radiation that I'm getting with a mammogram? Could you kind of give us a summary of your thoughts on that?
Sure. Yes. Generally speaking, the tomosynthesis is designed each image. So as I mentioned before, there are about 50 more images on the tomosynthesis compared to routine mammogram. Doesn't mean the dose at 50 times more. The overall the radiation dose of each image is significantly less. So overall, the entire tomosynthesis exam does have a little bit more. I would say about 120% more. I can have the hey Matt, can you show up that yeah. So this is that's a really nice slide from credit to Dr. O'Connor from Mayo Clinic. So he's, these are the numbers, these are measured in millisievert. It's the effective radiation dose. So if it's different than the other measurement of radiation. This is how when you radiate something, that organ respond to the radiation is differently from organ. You can put a very massive radiation dose to a rock that doesn't show much to respond. So do look at this. So the blue line on the right hand side is the limitation for radiation worker like myself, because I work with radiation during my procedure and stuff. So that is an annual allowed by the FDA, that how much I'm allowed to have radiation onto myself. So that is at 50 millisieverts. Now you can see there is a shaded grade on that screen called annual background radiation. Basically, if you live in the United States, Northern America, Northern Hemisphere, and you've been alive for 1 year, that's how much radiation you're gonna get. I don't care where you're hiding it, you're gonna get in that range. Of course, the on the right side of the range are people who live on the mountain, Colorado, and the range for the rest of the country. So you can see a bunch of blue line falls below that annual background radiation. Things like chest X-ray, bone density exam, DEXA scan. And you can see those there in there are the three things: mammogram, breast biopsy, and mammogram and tomosynthesis. So yeah, you can see that the mammogram and tomosynthesis is a little bit higher than the routine mammogram we've done before, but that remains pretty low below the annual background radiation that we all gonna get. Everybody, we're gonna have it as long as you survive for 1 year. As you go up on that scale, you can see that it's the cardiac screening, all those the cardiac exam that the cardiologist colleagues perform. CT lung screening cancers is definitely falling within that range. They can continue to go up. We're talking about the routine CT scan of abdomen and pelvis. If you have acute symptoms, you show up in the ER and the ED physician think you need a CAT scan of the abdomen pelvis. That is significant, many times higher than routine mammogram and tomosynthesis. So the short answer is yes, tomosynthesis has more radiation than routine mammogram, but the benefits here outweigh the risk. The additional radiation is very, very small compared to what is allowed and what is the medical imaging currently created. I usually tell the patient, because I explain to the patient all the time, it's like double your chance doesn't mean much. If you buy one ticket, you want to buy one ticket for lottery ticket, your chance of to win the Powerball extraordinarily low. You want to double that? Buy 2 tickets. You still
still won't be that good, right?
Low. Yeah, but you double your chance by doing so. So in the end, this it's been clearly to our medical community that the additional radiation risk is being outweighed by the benefit that this exam will provide to our patient.
Yeah, I like Susan was asking, does Medicare cover these mammograms, or what do they recommend?
Yes, Medicare does cover mammograms, and then the recommendation is based on your physician's recommendation. There's different recommendations out there. I think Dr. Bird and Dr. Pham, y'all can talk better about the recommendations.
Yeah, I'm not going to go to the recommendations today so much, Gina, but I want to go back to that viewer's question. And also, so would you one more time throw that up, will you, Matt? So in terms of Medicare covering, like they pay for these mammograms, Gina.
Yes.
They're paid for, was my understanding, right?
Yes, correct.
Okay, yes.
Yeah.
There's not an issue in terms of if you're
No,
Medicare.
and even if the patient were to end up with a balance, the Health Foundation has committed to taking care of that balance.
Okay, very good.
So
that helps.
Yep.
Okay, thanks, Gina.
Mm-hmm.
Hey, one bonus question. We have just a few minutes left here. Gonna for our viewers a little bonus screening question here, and that is about lung cancer screening. So I bring that up even because on the chart, the graph that Dr. Pham just showed about radiation exposure, there was a lung scan CT on there as well, which was also very low in terms of the amount of exposure radiation. Where was that at? That was okay. Yeah, Matt can probably light that up there, but it's kind of in the middle there. It's on the low. It's on the low side of the annual background. There you go, Matt. Thanks. Yep. Yeah. So anyhow, can you two of you want to talk a little bit about what we do at the hospital in terms of lung cancer screening via our CT scan?
I can start real quick about what the indications, and then Gina will talk about the logistic. Yep. So slightly different. Screening. The word screening implies that the patient is asymptomatic, right? So same thing with mammogram. Screening mammogram is routine. You do it every year. You show up. You don't have a symptom. The moment you have symptom, I feel a lump. That is a diagnostic exam. Same thing with lung screening. That when the patient fall into the indication, that is, they're very strict by the Medicare and CDC, that the patient has to have the certain number of pack years smoking. They have a long history of smoking. And they have to fall within a certain age range. I believe that 55 to 75 or 74 or so. And the key thing here, that was a significant difference here, is have to be asymptomatic. So, if the patient, there's a questionnaire that the patient physicians need to comply to, and for the patient to be eligible for lung screening, right? So the patient doesn't have chest pain, doesn't have fluid in their lung, doesn't cough up blood. Sure. It sounds very odd. It doesn't make sense to most patients. But once you have those cardinal symptoms like that, we are in the mode of diagnostic workup. Find out what is wrong with you. Screening is you have a higher risk. You have a long history of smoking, but you fall within the acceptable age, and you have to have no suspicious symptom of lung cancer. Yeah. So when that is met, the patient will have the lung screening. As you can see on that sheet, that graph that Matt put up, the lung screening is on the low end of the annual background. The routine chest CT is on the other spectrum. They are on the higher end of the annual background. So the CT lung screening that is recommended by CDC doing annually is very low compared to a diagnostic CT scan when the patient have symptoms. Yep. So because of that, the screening mammogram, the patient is self-referred. Any woman at the right age can show up, say, I want to get the screening mammogram. And that's self-referred. That means you don't need anyone to authorize you to do so. Right. On the other hand, the lung screening, because a little bit of higher radiation dose, as well as you have to understand the indication of that exam. So your physician need to check certain boxes for you to do.
Yep.
Yeah. What do you want to add to that, Gina?
I think he did a great job summarizing. The only thing I would add is your family physician can order this for you. You do not have to go to a pulmonologist. Okay. So just because it's the lungs doesn't mean you have to go to pulmonology. I would start with your family physician.
Yeah. And I'll add the concept of the lung cancer screening test is that, yeah, if you can catch some of these nodules very small, they either can be followed or sometimes they can be surgically removed before you have to go down the path of more advanced lung cancer treatments, which oftentimes involve radiation, chemo, and now other new modalities that are available. And the other thing I'll add is that lung cancer treatments for certain lung cancers has gotten a lot better in the last several years too. So it's another reason to get screened for that. Oh, and thanks for putting that out there. Yep, there's what Matt put out there. So, okay, well, Gina, Dr. Pham, I thank you for your time. Great information for the folks that are watching us today. And yeah, thanks again. And thanks for all the good work both of you do.
Yes, thank you. Thank you to all our Mammo staff. Y'all are doing a great job.
Yeah.
Thank you for inviting us.
You
Yes,
bet.
thanks for having us.
All right. Take care.
Bye-bye.
Yeah, so thank you so much to Gina and Dr. Pham again. And I'm not going to take a lot of time today because I've taken a lot of time with our conversation about breast screening. But I want to give you a few facts and news regarding COVID. So Matt will put up our charts. This is just like kind of our trend in terms of Whiteside County and the state in terms of positivity. Since last week, the county has added 6 deaths. So that has gone up some in the last week. Our case count, that was just one particular day, but it's kind of running in that range. I'm encouraged by the trend you can see in this graph here on the right is our current surge. And I do think we're moving in the right direction as far as that goes. So that's encouraging. Just as we've talked about before, the hospitalizations tend to lag that graph that you see in terms of weekly or daily cases, I should say. Okay, other facts that many of you may have heard about, just running by you just in case you haven't. So as of August 15th, the CDC put out the case rates based upon your status in terms of whether you've been unvaccinated or vaccinated by different vaccines. And I think August 15th is helpful because by August 15th, we were dealing with almost entirely Delta. That were the cases that were being seen. So I think these numbers are pretty solid in terms of these are Delta related numbers. So unvaccinated, there were 737 cases per 100,000 people. J&J was 172,000 per 100,000 people. Pfizer's 136 per 100,000 people. And Moderna's 86 cases per 100,000 people. So yeah, you can just kind of see that you're vaccinated. It makes a difference, and significant one. In terms of death rates, unvaccinated were 13 per 100,000 people. J&J were 3. So J&J is the least effective vaccine, and it still was quite a bit less than being unvaccinated. Pfizer was 1.4 per 100,000, and Moderna was 0.69 per 100,000 versus 13 for unvaccinated. So it's good. I mean, it's just showing that those are working quite nicely. What other facts did I have? Oh yeah, so this was another thing that came out from the CDC from June to September, which is mainly Delta time, that the Pfizer vaccine was 93% effective in preventing hospitalizations for 12 to 18-year-olds. And it was 75% effective if you had more than one risk factor, if someone was 12 to 18. So for instance, if they have obesity or something like that. So 97% of the people that were 12 to 18 years of age who were hospitalized during that time frame, 97% were unvaccinated. So yeah, and that's what we would expect, particularly for a younger group of people that are getting vaccinated. Their immune systems respond so nicely to vaccines that they have really good coverage once they get vaccinated. What other fact do I have? I think that's the facts for today. And then news-wise, just you've read about that the FDA is basically moving towards giving their thumbs up on mixing and matching. So if you've had the J&J vaccine, any other vaccines you've had, you can mix and match and have a different one now. And obviously the Moderna one, it appears is the most effective in terms of the numbers we're seeing right now. So I wouldn't be surprised if a lot of you watching and others out there would get their final booster perhaps being Moderna. So that being said, the booster I got was of Pfizer. So I didn't have a problem because I think that still is going to be very helpful in terms of protection. And the CDC is very likely here going to be okaying a 5 to 11-year-old vaccine. And that's going to be a lower dose in terms of the amount of vaccination product in that vaccine compared to adults. But anticipate that coming out soon. And it sounds like what they're going to be doing is sending those out to offices and stuff like that as well, so that when children show up into their pediatricians or family practice doctors' offices, they will be able to get that. I haven't heard any details of that locally and what that's going to look like, but as we have more information, we'll share that with you. Obviously, the thing with vaccinating that age group, those kids don't tend to get really sick with COVID by and large. What it does do, though, it's very protective, because what we're learning is the older you are, even if you've been vaccinated, it gives you it definitely protects you, but our immune systems as we get older don't respond as well. And so in many ways, what vaccinating children also accomplish for our communities and our country is it protects the grandmas and grandpas that these young children are around throughout the course of their days and weeks. And as the holidays are coming up, the holidays that they're around grandma and grandpa. And grandma and grandpa could get pretty doggone sick. And some of them, even who are vaccinated, can be hospitalized or die. So that's the benefit for the kiddos. Okay, it's good to receive the J&J vaccine back in April. Does he need to get a booster? And which one would you recommend to get the best response? They are now saying it is okay to mix and match. So if your husband is otherwise healthy, and that includes his body mass index is less than 30. And a lot of us don't realize that our body mass index is 30 or greater, which puts us in a higher risk because of our weight. But just assuming that if he doesn't work in healthcare, he doesn't work at a restaurant, he doesn't work at a grocery store, he doesn't work at a prison, he doesn't, there's a lot of these kind of caveats to that. If he doesn't fit in those criteria, he does not, and he's not a certain age, he does not need a booster right now. That's, at least right now, not the recommendation for him to get a booster. Thank you for the question, though. Who can get a booster shot? Yeah, so I'm going to ballpark it. I mean, you can pull up the CDC or IDPH websites and they'll give you more information. But basically, 65 years plus, booster. And 50, I think it's 50 to 65 if you have a risk factor, booster. And if you are 18 plus and you're in certain situations, certain settings, you have certain conditions, booster. And if you're a healthcare worker, grocery worker, prison worker, some of these institutional setting type of workers, like I mentioned previously, then a booster is the wording for the people like that are in healthcare and restaurants and those kind of things. The 65 plus is boosters. The wording is, I believe, should be given. And for folks who are in other situations like healthcare, prisons, institutional settings, may be given if you don't have other risk factors. I hope that didn't muddy the water, but that's my long-winded answer to that question. Anyhow, do we need to get a booster if you have breakthrough COVID 1 month ago? Good question, Susan. I don't know the answer to that. I'm going to write that down. I would say hold off on that until I get together next week, and I'll answer that question. I know Matt's going to be writing that down for me to help us remember that. Don't have an answer for sure. I'll get you back one next week. Thank you though. And by the way, I'm glad you're able to kind of watch our broadcast. So I'm glad that you made it through that infection. Okay, other news. I talked about the kiddos. They added, speaking of high risk factors, they did add some high risk categories to risk of getting severe disease recently. So cancer, heart disease, strokes, pregnancy, obesity have all been high risk factors for a while, which is why we encourage those folks to really get vaccinated. They've added people who have significant lung disease, liver disease, mental health issues, interestingly enough, and also people who have tuberculosis. So just wanted to get that out there. Want to make sure I don't have any other news to throw in there. I believe that is it. Hey, thanks everybody for taking the time to watch our program this week. We are grateful for those of you who pop in and take the opportunity to hear what we have to say, and hope that we trust that it's helpful information for you. We will continue to give you information that we have and we know, and we'll keep you updated on local things going forward with COVID. And we will continue to have some of these healthline, some of these healthy things to talk about, like the breast cancer every month or so, just to keep you informed of other issues going on from a health perspective here in Sterling and the surrounding area. So until next week, thank you so much for listening, and we'll see you next week.